Welcome to our webinar. I'm Dr. Irene Richard. I'm a movement disorder specialist, and I serve as the director for the Parkinson's Foundation Center of Excellence at the University of Rochester. So today we're going to focus on issues that face people with Parkinson's disease when they're hospitalized. Our panel of speakers will be reviewing the issues in more detail, but I just wanted to set the stage with a brief overview of the issues, as well as the steps that we've taken to try to improve the quality of care for hospitalized PD patients. And this was through a project supported by the Parkinson's Foundation. Well, the fact is that people with Parkinson's disease are more likely than those without to require hospitalization in the first place. And they have an increased risk of medical complications, they have longer stays, and higher rates of mortality. So we had two main goals. First, we wanted to educate hospital providers about Parkinson's disease. And second, we wanted to work with the hospital administration and staff to modify some of the standard hospital procedures to make them more suitable for Parkinson's disease. We decided to focus on Highland Hospital. It's a moderately sized community-based hospital that is part of the University of Rochester medical system. Okay, so the reason why we chose provider education as one of our main goals, basically most hospital providers who work directly with patients, and that would include physicians, nurses, physical therapists, even those who are otherwise excellent clinicians are not familiar with the nuances of Parkinson's disease. And this is especially true for issues that are relevant to patients who have advancing disease. Best example probably being motor fluctuations. So most providers are not aware that patients can transition from being on, during which their Parkinson's medications are working and their symptoms are well controlled, to being in an off period when the medication effect wears off. They experience a reemergence of symptoms and often with markedly reduced mobility. In addition, it's patients with motor fluctuations who often have very complex medication regimens. And for them especially, the timing of administration of the medications is crucial. So getting the right medications at the right time is one of the biggest challenges for people with PD who are in the hospital. Now, this isn't a new realization. In fact, there have been concerted efforts underway for a while to address the problem. The Parkinson Foundation began their Aware and Care campaign almost a decade ago. And this program focuses on educating patients about issues related to hospitalization and provides them with resources, including an Aware and Care kit, which you'll hear a little bit more about later, that contains valuable tools for patients and care partners, including information to be shared with the hospital staff. What's been clear over time, however, is that while educating the patients and providing them with resources is undeniably important and does have the significant potential to improve the hospital experience and outcomes, it isn't enough. Even when patients did their homework, as it were, and brought the kit to the hospital, they found that attempts to share that information with staff and providers was a significant challenge. Providers seemed reluctant to take the time needed to review the materials. Ironically, this is probably because they are not aware that the patients have knowledge and that the kit contains important information that they don't know but should. So we decided to approach the issue at the provider end of the equation. In effect, to let them know what they don't know, how this impacts the patients, and then to give them the knowledge they need. I think it's important to realize that hospital providers overwhelmingly want to give patients the best possible care. So we essentially wanted to close the loop so that both patients and providers are aware and can work together to achieve their common goal of improved hospital care. I'll give an example scenario. So let's say there's a provider, attending physician, and he goes in to see the patient, Mr. Jones, at 9:30 in the morning for morning rounds. Mr. Jones looks great. They're able to converse with back and forth. Mr. Jones can do all of the maneuvers for the exam. In fact, he even walks to the bathroom as the doctor is leaving the room. So the physician thinks that the patient's ready to leave and looks great, puts in a request for physical therapy to come by and see the patient in order to, quote, clear him for discharge. So the physical therapist gets the request and goes up to evaluate the patient only an hour later, so at about 10:30 a.m. At this point, however, the patient's hardly able to move. So the physical therapist informs the physician that the patient can hardly walk and certainly doesn't appear ready for discharge. Well, each of them is confused about the other's description. And the physician even asks the therapist, wait, are you sure you went to the right room? And you saw Mr. Jones, the bed by the window? The therapist is probably thinking, did you see the right patient? But they often have better social skills. Well, what we know, but they didn't, is that the physician saw the patient when his medications were working and he was in the on state. The patient, Mr. Jones, got his 6 a.m. Sinemet dose, but he didn't get his second scheduled dose that was supposed to be given at 10 a.m. So by the time the physical therapist saw him at 10:30, his medication had worn off. Okay, so the next goal of ours was to address hospital system modifications. And we worked with the hospital administration staff to modify some standard procedures, including the process by which medications are ordered using the electronic medical record. Because let's say best case scenario, and the patients and the providers have all the knowledge that they need and the desire to do the right thing, meaning the patient knows that they need to take their medication at 6 a.m., 10 a.m., 2 p.m., and so on. And the doctor puts in the orders through the electronic medical record system for the patient to get his Sinemet every 4 hours starting at 6 a.m. Well, the system currently is set up in such a way that this may actually not happen. For example, hospitals typically consider the administration of medications to be on time, as long as it's within a certain window. So let's say give or take an hour of the ordered time. And this is because it's generally acceptable from a clinical standpoint for patients who don't have Parkinson's disease, and it's obviously much more feasible for busy nurses and staff. However, this is obviously not acceptable for the patient with Parkinson's disease, particularly someone like Mr. Jones, who may suffer from extreme worsening of symptoms to the point of immobility if his medication is delayed, even by minutes. So with that introduction of what we did and why we did it, I'd like to introduce Dr. Blanca Valdovinos.
Thank you, Dr. Richard. I am Dr. Blanca Valdovinos. I am a movement disorders neurologist at the University of Rochester. I also completed a one-year movement disorders fellowship where I learned from and took care of many people with Parkinson's disease. And I'm also the Parkinson's Foundation Center of Excellence co-director at the University of Rochester. I've worked with the team on this project for the past year and a half. It's something I'm very passionate about, and I'm very excited to share this with you guys. So I think the first thing I want to talk about is why we decided to undertake this initiative. So a couple of things that we know. One is that people with Parkinson's are at an increased risk of hospitalization. And this is because Parkinson's is both a chronic disorder and progressive. And a lot of times, when you're hospitalized, it can be from a Parkinson's specific complication, or it can be from a complete different medical issue. And also, we also know that people with Parkinson's who are hospitalized have a higher risk of developing medical complications in the hospital. So at increased risk of developing delirium or being confused. There's also, they also have longer hospital stays. So studies show that on average, people with Parkinson's have 3 days longer hospital stays than those without Parkinson's disease. And then there's also a decrease in the level of function due to being hospitalized. So this is because when you're in the hospital, you're not moving as much, you're not as active, you can become a little deconditioned, muscles get a little weaker. And then another thing that happens is that once our patients are getting ready for discharge, what happens is that you have a team in the hospital. And you typically are evaluated by the hospitalist, who's the main doctor taking care of you. But there's also a team of physical therapists who evaluates you prior to discharge. And the physical therapist and your team decide whether it's safe for you to go back home or not. In some cases, it is deemed that, it's safer for our patients to go to a skilled nursing rehab after the hospitalization for a time period before they go back home. And, Parkinson's can also, when you're hospitalized, can potentially increase your risk of mortality as well. So our project goals. So our first goal was to improve the hospital experience for you. And the second goal was to improve the quality of care. So how did we accomplish this? So one of the main things, like Dr. Richard was mentioning, is we worked closely with hospital administration and staff. About a year and a half ago, Dr. Richard met with the administration at Highland, and she proposed this project. And everybody in the hospital embraced the idea, and they were very thrilled to kind of engage with us. And I think this just goes back to the fact that, in the hospital, your team is doing their best to take care of you. And a lot of times we just need to help them a little bit more through education and equipping them to better take care of you in the hospital. One of the other things we're doing is focusing on a multidisciplinary care team. And what that means is that when you're in the hospital, the primary doctor is a hospitalist. So a hospitalist is a doctor that's trained in internal medicine. And typically they also work with a nurse practitioner. There's also nurses taking care of you. Physical therapists are often involved. And in some cases, occupational and speech therapy are also involved. It's important to know that in the hospital, neurologists are not always available or part of your care team. And this is why this project is so important, because we want to make sure everybody who's part of your team in the hospital, is equipped and has the knowledge to take care of you. And then we also work closely with medications. So Dr. Braun, who you'll hear from later, has worked closely with pharmacy at Highland Hospital to try to make sure that, we make everybody aware of medication timing. So medications are given on time, and medications include specific timing, not just take this medication twice a day or 3 times a day, but that includes specific information about the times when you take your medication. And we're also making sure that people are aware that some medications can be potentially harmful in Parkinson's, and that those medications are not ordered for you. And, we also just want to make sure everybody's aware about these medications, and that the medication regimens can oftentimes be very complex. And another way that we're also doing that is through educational programs that I'll talk about in the next couple of slides. So in this slide, I think it's very important to talk about the importance of provider education. And what we did is we identified individuals from each discipline in the hospital to be PD champions. So these are experts. And, I'm going to use this time to thank the Parkinson's Foundation, because through their sponsorship, we were able to go, a team of 8 of us were able to go to allied team training for PD. This was a training program in Charleston, South Carolina last year. And there was 8 of us in this picture. On the left, we have Amy, who's a nurse. And then next to her, we have Molly, who's a speech therapist. We have Ellen, who's an occupational therapist. Next to her is me, so movement disorders neurologist. Then we have Dr. Dylan Ruebeck, who's a hospitalist. Next to him is Aubrey, who's a physical therapist. And in the back stand, we have Jess, who's also a physical therapist. And in the back, we have Vahid, who's a nurse practitioner. So I think this training program was very significant for all of us. I think it was a wonderful experience. We were there for 3.5 days, and we all worked together as a team for part of it, where we kind of came together. We discussed ideas, ideas to kind of make the hospital stay for our patients better. We learned how to communicate better as a team. And we also were broken down into subgroups where we had discipline-specific lectures and small group discussions. For example, Jess and Aubrey had, lectures that were specific to physical therapists, but Dr. Ruebeck, and I, we had lectures and small group discussions that were specific to medical providers. So I think this program really kind of helped us learn a lot about Parkinson's disease and how we can all work together to improve the hospital experience for you. And when we came back, the goal here was also to help educate colleagues in the hospital. So if there's ever a PD related issue, we become the point person in the hospital that, our colleagues can come to us and ask us, I have this patient who's admitted, what can I do better? And I think this is why, we're just very thankful for the Parkinson's Foundation to help sponsor and help pay for this training program and helping us all travel to the conference last year. So a couple more contributing factors that we thought could be addressed. So one of the things that we've touched base on is kind of the knowledge gap among providers. And what we know is that these doctors, the hospitalists, nurses, nurse practitioners, physical therapists, they all do want to know more about Parkinson's disease. And they're all very open to knowing more about Parkinson's disease. And, a lot of times they just don't have that experience, seeing people with Parkinson's disease in the hospital. For example, I'm a movement disorders neurologist and I have a clinic, and I typically see, people with Parkinson's in my clinic. But typically a lot of the hospitalists, they see a variety of different medical disorders and take care of many different patients. So they just don't see them day to day as often as we do. So I think that's one of the big things that we wanted to use this project to just really make sure that all providers, had knowledge of Parkinson's disease. Dr. Braun and I have been given 1 hour educational sessions at Highland, where we basically talk for an hour to hospitalists and nurse practitioners, and we educate them. We go back to the basics. What is Parkinson's disease? What are the motor features of Parkinson's disease? What are motor fluctuations that can happen? We go over medications with them, and we go over the medical side effects for medications as well. So I think these are all things that we're trying to work with the hospital. And we've also given talks to physical therapists, occupational therapists, and speech therapists, where we're just trying our best to educate everybody in the hospital about Parkinson's disease to improve your hospital experience. And then also, once again, we do have, we know that there are many standard hospital procedures that are not adequate in Parkinson's disease. And this kind of goes back to medications. And again, Dr. Braun has been doing a great job working with pharmacy at Highland to make sure, pharmacists are changing the way things are ordered in the medical system, and that we also educate providers as well. So now I'm, going to turn it over to Dr. Dylan Ruebeck.
Hello, can everyone hear me? Hello, my name is Dr. Ruebeck. I'm one of the hospitalists at Highland. It's a pleasure to be here. And before I get started, I'd love to tell you guys a little bit about what a hospitalist is. Not everyone's familiar with this term. So we're basically generalists or internists, much like your primary care doctor. However, we work in the hospital, and our patients are patients who need to be in the hospital for their care. They have to be in the hospital to get that level of care that they need. And we see a variety of different diseases and conditions, and that includes Parkinson's disease. And that's why it's so important to have these programs set up by the Parkinson's Foundation. We greatly appreciate all of the education that has been given to us, and it's been a great asset to Highland Hospital and patient care as a whole. So, as was previously addressed, hospitalization, unfortunately, is more common amongst individuals with Parkinson's disease. And here, there's a study that delved into this and felt that about a third of patients with Parkinson's disease are hospitalized within the span of a year. And once these patients are hospitalized, it seems that they're rehospitalized at a higher rate. They can be up to 50% more likely to come back to the hospital within the next year. And what are the reasons for hospitalizations? There, of course, are many. But here are some of the common reasons. One would be surgeries. Some of the surgeries might be particular to the Parkinson's disease itself, such as deep brain stimulation surgery. Others might be different, such as gallbladder surgery or knee replacement that may require hospitalization. Also, as Parkinson's disease progresses, gait instability is certainly prominent, and an increased risk of falls coincides with that. And these falls could lead to injuries such as fractures and could result in needing hospitalization. And additionally, with Parkinson's disease, there can be issues with swallowing safely, and food and saliva can go down the wrong pipe and potentially go down the trachea and into the lungs, leading to what is called aspiration pneumonia. And there could be other infections as well that could lead to needing to be in the hospital, typically to get IV antibiotics or fluids and whatnot that would be hard to obtain through your primary care doctor or outpatient. Also, confusion or delirium, kind of an altered mental status, can bring you into the hospital as well. In the hospital, we can expedite or work up into why there's an increased confusion. And then once we figure out and get a better sense of why there's confusion, we can start treating that and trying to get things in a better place. So definitely things can move a bit quicker sometimes in the hospital than would be done more in the outpatient realm. And there's issues that we can run into in the hospital with individuals with Parkinson's disease that we need to be mindful of. I'll go through them. Orthostatic hypotension basically means a significant drop in blood pressure when changing position. For instance, going from laying down to standing, that gravity can drop your blood pressure. Normally our cardiac system is able to kind of compensate, but that is blunted with Parkinson's disease. And we need to be aware of that because this can increase the risk of falls or significant lightheadedness, especially when acutely ill and needing to be in the hospital. Another thing is individuals with Parkinson's disease are more likely to become confused in the hospital. The hospital in and of itself is a disorienting place. It's not always quiet. There can be a lot of disruptions and beeping and people coming in and out of the room, such as nurses that are checking in on you. The sleep-wake cycle can be disrupted. It can definitely lead to confusion, especially when, if we're sick, we have an infection. So it's definitely something we also have to be mindful of as well. And another aspect is motor fluctuations, which Dr. Richard and Dr. Valdovinos eloquently discussed earlier. The on and off phenomenon we need to be aware of too. The physical therapy conundrum that Dr. Irene Richard mentioned, we need to have a better sense, did they take their medication or not? Are they in an off or on state? And then also, as was previously mentioned too, the advanced Parkinson's disease individual can be on a lot of different medications that we might not be familiar with, or maybe we're not timing them right in the hospital. So we need to have a good foundation of knowledge about these medications ourselves. And as Dr. Valdovinos mentioned too, there are certain medications such as medications for nausea, medications for confusion that can potentially worsen Parkinson's disease symptoms. And a lot of these medications are relatively commonplace medications that are used very frequently in the hospital, but with patients with Parkinson's disease, we could be doing them harm by giving it to them. So we really need to know that when we're prescribing our medications. And now I'd just like to briefly give an anecdote about one of my patients that I was taking care of before I introduced Dr. Braun. where this patient was in the emergency department and was admitted under my care. And she was relatively advanced in Parkinson's disease, and she was on a frequent dosing regimen of Sinemet. And she herself emphasized to me her need to get her Sinemet on time. And unfortunately, she was down in the emergency department, and emergency nurses are running all over the place. Sometimes things can get a little chaotic down there, and her Sinemet wasn't given to her in a timely fashion. It was delayed by a couple of hours, and she did experience significant downtime from that. And it wasn't a positive experience. And, you know, I felt terrible that her hospital course, just getting admitted, wasn't optimal. And thankfully, with my background through this program, you know, I was able to quickly see what the problem was and talk to the nurses and really get that medication as soon as possible and make sure that that issue wasn't a recurrent issue during her care. Now I'll love to hand things over to Dr. Braun, who will tell us a little bit more about medications and their importance in the hospital.
Thank you so much, Dr. Ruebeck. So my name is Dr. Melanie Braun, and I'm a neurologist at the University of Rochester, and I'm currently doing my movement disorder fellowship, meaning that I've finished my neurology residency, and I'm actually spending 2 years doing this fellowship, specifically studying movement disorders, of which Parkinson's is the most common type. And I'm also really grateful because my fellowship has been funded by the Parkinson's Foundation. So I really appreciate their support. So as it has been alluded to by the prior panelists, I'm going to be focusing on some of those medication issues. And I'm going to break it down basically into two big problems. The first one being the issue of getting the Sinemet or other medications on time. And the other one is avoiding those medications that can worsen the symptoms of Parkinson's disease. So I'll start with the first one. And as a lot of the doctors have already mentioned, these regimens are often very complex, and they would be complicated for anyone. I'm amazed when my patients are able to tell me I take it this time, and it's all this big chart. It's really hard to keep track of. And also the timing is so crucial. And for anyone with Parkinson's or someone who cares for someone with Parkinson's, you know that the timing of that medicine can be down to the minutes. It could be, I know if it's a half an hour late, I'm going to get my off symptoms. And this is honestly pretty unique to Parkinson's. There's not a lot of other disorders where the timing is so important. And for example, say your cholesterol medication, you might be able to take that at any time of day. And if you're 4 hours late, it's not going to be a big difference to you. No major issues there. But with these Parkinson's medications, it is a big issue. And, the hospital providers, as has already been discussed, are becoming more aware of this because of this education that's occurred at Highland. But still, it's a message that we're trying to reinforce. And even if they are aware, there's still problems that are kind of fundamental to the electronic medical record system, and also just the culture of the hospital. As Dr. Richard mentioned, there's a typical 1 hour window to be able to receive your medications. And that's because of the pace of the way the nurses work. They have multiple tasks they have to do. And, even that 1 hour can be a really big deal for some patients. And then if it's late, if the medication is delayed beyond that, sometimes they may be even due for that next dose by the time they're getting their first dose. So that's some of the big issue with getting your meds on time. And just to give you a sense, this graphic was from a study looking at patients who have Parkinson's disease in the hospital and just trying to see, when did they get their medication in relationship to their own schedule. And if you see the the blue part of the pie chart, that's within the expected hour. So that's really the goal. And, ideally we'd love it to be exactly on the dot, but there is that flexibility with the timing. And so about 38% of the patients, they got their meds on time. But you can see then, 14 and 15% of patients, it was pushed to 2 hours, and then it was 3 hours. And, by 3 hours, as I mentioned, that could be when you're due for your next dose. So you're getting kind of progressively behind on your medication. And my patients tell me a lot, when they miss that dose or they get behind, it's pretty hard for them to catch back up. And it can really lead to delays in their improvement while they're in the hospital. And then the big one is that in the purple part of the chart here, you can see those are patients where their medication was omitted altogether. And so you might wonder, why would that happen? So as Dr. Ruebeck mentioned, it could be issues with, the nurses feverishly working in the emergency department and not being aware of the crucial timing. There's some issues where occasionally the medication might not be in the pharmacy, or sometimes patients, they're off to get their MRI or another test. So there's a lot, or they might not be able to swallow, for example. There's a lot of issues, but having a third of patients have their medication omitted is a really big deal. And so now that second part of what I wanted to talk about, which is the medications that can worsen Parkinson's disease. So just to give you an overview of what these medications are, for your own knowledge, when patients go to the hospital, they may become nauseated, or they become confused, agitated for a variety of reasons. And it's not just Parkinson's patients who can experience these things. This is very, very common in the hospital. And so the providers, typically give the same types of medications in these situations. And as Dr. Ruebeck said, for the most part, if you're an individual who does not have Parkinson's disease, these are really well tolerated medications. For example, one that a lot of people may have heard the name of is something called Haldol or haloperidol. And that's an antipsychotic medication that can be used for confusion or agitation. And the issue is, the reason that this should not be given in Parkinson's disease is that this is a medication that works by blocking the dopamine. So why is that a problem? As we know in Parkinson's disease, the problem is that the dopamine is already low in the brain. So further blocking the dopamine would end up worsening these symptoms. And people can become incredibly immobilized, their tremors are worse, they're unable to walk. And so it's crucial to avoid this. Fortunately, there are alternatives that can be given, which I can mention on the next couple of slides, but same thing for nausea. There's some nausea medications that block the dopamine, and so we want to avoid these. And plenty of studies have been done to see how often are patients with PD receiving these medications. And one study showed, or a handful of studies have kind of found, about 20% of patients are receiving these medications. So it's definitely still a big deal that we're trying to work on multiple ends, that both the patient's knowledge and the provider's knowledge, so to try to address this. And so this was our goal with this project regarding the medication part, was to make sure patients were getting their meds on the right time, right schedule, and that they were not receiving these medications like Haldol. And so how did we go about this? A lot of it was done before I joined the project by my colleague, Dr. Katie Amadeo. But I basically joined on and learned about a lot of work had been done with the pharmacy at the pharmacists at Highland Hospital, and also with the creators and experts of the medical record system. And they actually were able to look at how often these wrong medications, for example, something like Haldol or another dopamine blocker, was ordered on patients with Parkinson's disease. And they found it was happening at a high enough rate that they actually created a safety alert, like a warning advisory, such that anytime someone who has a diagnosis of Parkinson's or related disorder, anytime one of these medications that block dopamine was ordered, they would get a big flag that said, this patient has Parkinson's disease. We don't recommend the XYZ medications. But also they were able to say, these are the medications that would be safe in this situation. For example, something like quetiapine or Seroquel could be given if a patient is experiencing agitation. So now that's in effect with the entire medical records system at the University of Rochester, both at Highland, strong within the entire enterprise. And that's been in effect since January of 2020. And then additionally, we made sure that when the doctor is ordering your Cinemet, for example, that they weren't relegated to just saying 3 times daily in the order, and they were able to say, take at 6 a.m., 12 p.m., 6 p.m., for example. And so we wanted to ensure that every patient had their home regimen ordered. So that is what I want to talk about medications. And now I want to turn it over to Dr. Aubrey Masakowski.
Thank you, Dr. Braun. I'm a physical therapist at Highland Hospital, where I've been working for just over 8 years now. I received my doctorate in physical therapy from Nazareth College 10 years ago, and I've worked as a therapist in both the hospital setting as well as acute rehab setting. In the hospital, especially at Highland, there is a strong focus on the interdisciplinary team approach for patient care. Specifically, doctors, physical therapists like myself, speech pathologists, occupational therapists, and social workers work closely together to address all aspects of care for our patients with Parkinson's disease, and early involvement with these disciplines is key. As a physical therapist in the hospital setting, we work with patients at all levels of physical and cognitive dysfunction related to their Parkinson's disease. We may be working with patients who present to the hospital for a decline in function, deconditioning related to an acute illness, or an adverse event related to a fall. As acute care therapists, at the center or the core of what we do is to play an integral part in the discharge planning team. We are heavily involved in making assessments and recommendations for what you or your loved one may require additionally at home in order to be successful and remain at home for as long as possible. This may include equipment recommendations, a recommendation for home physical therapy, or supplemental assistance programs such as aid services or Meals on Wheels. We may recommend or refer you to outpatient or community-based services such as rock steady boxing or physical therapy in a private clinic setting. We may make recommendations for you to receive short-term rehabilitation within a facility in order to maximize your independence and return to your baseline level of function. We may also play a role in deciding if a person with Parkinson's disease will ultimately require an increased level of care. Above and beyond the role that we play in discharge planning, we place a major emphasis on early out-of-bed mobility and activity in the hospital setting. This can help mitigate the risk for some of the adverse effects of prolonged bed rest that can be seen in this patient population, such as pneumonia, delirium, decline in function, and falls, among other things. As we work with you in the hospital setting, you may find us working on your balance, your posture, range of motion and flexibility, exercise and strength, fall prevention strategies, and gait training. We have several tricks and strategies that we can use to help our patients with Parkinson's navigate some of the debilitating gait impairments that are characteristic of this disease, such as the shuffling of gait, the freezing of gait, and fascination of gait, all of which can place you or your loved one at increased risk for fall. I do want to expand slightly more about exercise for those with Parkinson's disease. Exercise is gaining great awareness in its ability to aid in the management of Parkinson's disease, and evidence suggests that it may play a major role in its ability to slow the progression of the disease. Specifically, studies have shown improvements in many of the motor as well as some of the non-motor symptoms of Parkinson's, such as attention, cognition, strength, balance, gait quality, fall risk reduction, and improvement in overall quality of life. It is recommended that you or your loved one receives 150 minutes per week of mild to moderate intensity exercise, and a combination of exercise modalities is recommended. It is important to note that while you are hospitalized, you may not tolerate or be appropriate for this level of activity. However, any movement or activity away from sedentary or out of the hospital bed is more than beneficial for patients with Parkinson's. In fact, it is crucial. As I mentioned previously, in the hospital setting, physical therapists work closely with many members of the interdisciplinary team in order to deliver the best, well-rounded care that we can for our patients with Parkinson's. Even more specifically, we work closely as a team with our other rehab counterparts to address many of the motor and some of the non-motor symptoms of Parkinson's disease that you can see depicted here on this slide underneath the tip of the iceberg, or in other words, some of the other symptoms of Parkinson's that may not be as noticeable on the surface. My speech pathology colleagues will work with you on any of your speech or swallowing impairments. They may perform bedside or image-guided evaluations of your swallowing function or ability, and they may make some recommendations for an altered diet or swallowing strategies that will allow you to continue to safely consume food and hydration. My occupational therapy colleagues will address your ability to participate in the activities of your daily living, such as dressing and bathing, as well as your cognition and safety. They may recommend adaptive equipment to improve your independence with these tasks, or they may instruct you on compensatory techniques to improve your independence and function. They may also address your overall cognition and safety with medication management. Something I feel that is important to note is that early intervention with all three of these disciplines is recommended, even in the early stages of the disease process. Unfortunately, in the hospital setting, we're likely working with you as a patient with Parkinson's that has had an adverse event. At times, the hospital setting may be the first time a person with Parkinson's disease has addressed their impairments with an occupational therapist, physical therapist, or speech pathologist. I wanted to switch gears briefly to talk about the role that physical therapy plays in the advocacy for compliance with the medication regimen in patients with Parkinson's, especially as it pertains to medication timing and motor performance. As physical therapists, we are acutely aware that even when our patients are optimally managed on their home regimen, they can still experience sometimes great fluctuations in their motor abilities. We also acknowledge that by the time you or your loved one arrives to the hospital, it is very possible that you may, in fact, already be 1 to 2 doses of medication behind. Then, because we take such good care of our patients in the hospital, you are likely to be whisked away for tests, images, blood draws, or other things, and your medications may be further delayed due to competing priorities in your care. By this time, it is liable that motor symptoms can be through the roof, and it may appear to various levels of providers that you are much lower functioning or less capable than you really are. This can unfortunately lead to a downward spiral. This is why I'm so thankful for the changes that have been made within our system that have placed such an emphasis on receiving the right medications at the right times to allow our patients with Parkinson's disease to be successful during their stay. And now I would like to introduce Amy Chesire from social work.
Hi, thank you so much, Aubrey. I appreciate that. My name is Amy Chesire, and I am a licensed clinical social worker and also a family and marriage therapist. I've been here working at our Parkinson's Foundation Center of Excellence for the past 20 years or so. So seeing and taking care of patients that are living with Parkinson's disease, as well as trying to assist their families. So today I was going to basically kind of share about 3 different things. One, I'm going to talk about initially sort of the community outreach efforts that we've had around this. Then I'm going to talk a little bit more about a hospital-based social worker and what you can expect from them, as well as wrapping up with some specific resources related to hospitalization. So as was kind of initially discussed, there was kind of a two-prong approach to our efforts to try to help improve the overall quality of life for folks that get hospitalized that have PD. And one of the things that we recognized that was also important was to really kind of get a sense of what's currently going on for families that had somebody in the hospital. So in the early days of the grant, then we reached out and pulled together what we kind of called focus groups as a way to kind of have some conversations, basically. We looked for folks that had been recently hospitalized about the past 12 to 18 months or so. So the experience was, relatively still etched in people's minds. And these were small groups that we pulled together. They were made up of people that had Parkinson's disease, as well as caregivers or other family members. And we came together for about 1.5 to 2 hours. And we really recorded these and sort of took verbatim what everyone was trying to share with us. So this is just an idea of some of the questions that we asked. There were more than this, but this is kind of a nice cross section. So we wanted to hear basically, what was it like? What were the things that you thought went pretty well? What were some things that maybe could be improved upon? In particular, I think wanting to know, what did you experience was the hardest part of things, both for you as a family member and as well, obviously, for the person that had Parkinson's. And also to definitely hear around this issue that's been a common thread throughout all the speaking today is, how hard, what kind of issues did you encounter related to getting your loved one's medications while they were in the hospital. So this next slide just gives you, this is verbatim, actually, some of the direct feedback that we got from the care partners. And you can see, in particular, the hospital staff, the rehab team seemed to have expectations of my dad with PD that were higher than what we felt was reasonable. They didn't seem to quite understand the extent of his Parkinson's disease. Or another woman that shared the overnight hours were the hardest, as my mom's hallucinations would often worsen as the sun goes down. I wanted to stay with her, but again, I had young children that I needed to care for. I had to trust the hospital, which at times could be hard. And the last one that I think gets at the heart of everything that we're trying to kind of share with folks today is I felt that I knew so much more about my husband's Parkinson's, and it was hard to advocate for his medication needs. In particular, I knew what medications he should not take, and yet they wanted to prescribe it, and they didn't necessarily want to listen to me. I felt very angry and frustrated. And so a big part of this project is trying to really get at that issue in particular and to try to sort of unload some of that burden that I think certainly people with Parkinson's, but certainly their family members often feel when you have a loved one going to the hospital because now your care has been turned over to someone else, and you can often feel pretty, at times, kind of hopeless and certainly powerless. So trying to institute these changes at sort of the back end and at the hospital end, our hope is will help to lessen some of that burden for families. And I also wanted to give a huge shout out and thank you to all these families that gave of their time and their expertise to us and their wisdom. We really appreciated it. So next, I kind of wanted to talk about the hospital-based social worker. And this is just to kind of go along with the social worker is another member of the multidisciplinary team. And some people are aware of hospital social workers, some folks aren't. So I thought this would be a good opportunity. I just listed up here a number of ways that an inpatient or hospital-based social worker should be of some help or support to you. And so this should really be, kind of across the country. I would say these are pretty general ideas, but in particular, I wanted to point out to families that because our healthcare system has gotten incredibly, I think, more challenging and more complicated in some degrees, that often you can turn to whether it's the unit-based social worker or someone that maybe is covering a couple of units, but you can really turn to the social worker to kind of help be that sort of navigator for you. That's kind of can serve as more of sort of a point person to really help steer you in the right direction. And if you're running into issues, can be sort of an advocate for you to help steer you in the right direction and provide the support, whether that's more counseling support or whatever type of help sort of that you might need to kind of navigate the system. Obviously, the social worker can also help with a lot of what I call kind of more the nuts and bolts of things, sort of really helping to coordinate what's going to happen after you leave the hospital. That tends to be, you know, these days we start talking about discharge planning when you haven't even been in the hospital very long. Again, it's a little bit the nature of the medical system. So we'll start talking about this pretty early on into someone's hospitalization stay, in particular if the plan is perhaps that you're not able to return back home directly. So really trying to figure out and work with the other rehab providers like Aubrey, like physical therapists and OTs and speech to figure out about placement and is that rehab based or is that nursing home and what kind of evaluation is really needed. And I think importantly, kind of working with the team and helping to sort of interpret that back to the family, because you can get into a lot of lingo. It can be a very kind of complicated system when you're looking at, you know, maybe not being able to return home directly. So the social worker should be able to kind of help guide you with that. And obviously, if you are going home, referrals to things that are out in the community. Whether that's some pretty basic things like transportation, how do I get to places, how do I get to medical appointments, having unique ways often that a social worker might have at his or her disposal around helping with medication co-pays, you know, and a variety of things that you might need once somebody is returning back home. And the other thing is always kind of around medical insurances and the complexities of all that. A lot of larger hospitals tend to really also have financial counselors that are on board. And so often a social worker actually may, if that's at their disposal, refer you over to the financial counselor to help with a lot of that kind of nitty gritty. And the big thing is just to ask if you haven't had contact with a social worker and your loved one, you're in the hospital, and certainly if you're in the hospital for any period of time, to definitely ask on the unit that you want to make contact with the social worker as soon as possible. So don't forget to ask about that. So these are then to shift into kind of resources. You've been hearing a little bit about this throughout today's talk. So just to talk a little bit more specifics about, this is a picture of the Aware and Care Kit. Hopefully many people already have these at their disposal. If you don't, I know we're providing information, I think, throughout the chat about how you can, various ways that you can get one of the kits. But just to highlight, the kits really started back in 2011 and came out of, I think it was an initial paper actually from 2007 trying to evaluate early on what are some of the issues that were going on for people with Parkinson's. And it's been through a number of renditions in its time, which is great. And actually then starting by 2017, the foundation added what they call Aware and Care Ambassador Program. So these were folks within various communities across the United States these were people that really could act as additional kind of supports and ambassadors for folks when they were getting hospitalized, and they could also really help guide you around the use of this kit. A couple things I'll point out. I was glad to see that I think the kit's a little less sort of cumbersome in some ways that it might have been in its early days. So, you know, the recommendation, I believe, is to generally try to have about 4 days worth of medications that are in this kit, and to keep those obviously as current and up to date and in the original pill vials and all those things. But that's sort of kind of a pretty global recommendation, which I think is, and to have it readily available and know where it's at and who's going to bring it. Of course, all this is much easier if it's a planned surgery, but so many hospitalizations are not planned. And happen perhaps more in emergency or crisis situation. And that's one of the lead-ins of the kit as well, is that each family ideally should kind of have a sort of hospital emergency plan. In other words, what are we going to do if all of a sudden, you know, my mom with Parkinson's needs to be hospitalized? Who's going to be, you know, bringing in the wear and care and kit? Where's it going to be kept? Who's going to notify your outpatient neurologist? So kind of having a plan, which I think we always tend to function a little bit better when we have a little bit plan, or at least folks have talked about it and have an idea of things. The other nice thing I'll point out about the kit is they do have a very nice bracelet that's in the blue and silver colors, actually of the foundation, but that you can wear it anytime, quite honestly, but it just identifies, it's like a Parkinson's disease alert bracelet. And it also has a really nice wallet card that people can carry around, that really talks specifically about some of these medication issues, explains about Parkinson's disease, and explains who your outpatient doctor is to contact. So a wealth of great resources are in that kit. So again, I really encourage folks, if you haven't gotten it, to pick that up. The second one I have on here is you can go on to the Parkinson Foundation website, which is parkinson.org. And this is for /letter. And so this is going to pull, this letter was actually developed in the early days of COVID. So it's a one-page letter that specifically highlights, this is signed by your outpatient neurologist with their contact information on it. And so if you don't have the aware and care kit, or you can't find it or whatnot, this is a letter ideally that your neurologist would have signed ahead of time. And it really outlines, I think it's about 8 to 10 kind of different really specific things for folks to, basically condenses aware and care and condenses today's conversation kind of down into one page. And you can then bring that with you to any hospital that you're going. And it really highlights 2 big sections around the medication issue. So that's also another just resource that's readily available. Like I said, you can get that pretty easily and download that and get it signed and have it at your disposal. The other nice one is one that was done also in the earlier days of COVID back in April 2020. If you want to check out on the Parkinson's Foundation, this is on their YouTube channel. It's called Ask the Expert, Parkinson's and Hospitalization. Very nice video that was done. It has pretty much more of a question and answer format. A lot of that is kind of related to COVID, but also some general Parkinson's hospitalization. So if you want to see some further videos, I would encourage you to check out that. And the other one, last one on here, is around specifically the thing that we also talk about is making sure whenever you're going into the hospital, that you do want to make sure that you know what's going on with your advanced directives. So these are things like your healthcare proxy, in particular, where you have appointed someone else to make healthcare decisions if there ever comes a point in time when you're not able to do that, as well as If you're coming from a facility, this will go by different names across the country, whether it's a MOLST or a PULST. So these are your specific guidelines of what you want to happen with your care. So this was a nice fact sheet that the Parkinson's Foundation pulled together to really help remind people of how important it is to be as mindful of your advance directives if they needing to be changed or updated, and just some nice tips about how to manage and how to take care of all of that. So I think that's going to bring us to the end of everyone that's talking at you. And now I'm gonna turn it over to my colleague on here, Jill Lowell, to help start us with the next section to kind of answer your questions. Thank you.
Thank you, Amy. So now we will go through some of the questions that have been brought to our attention either prior when you were registered for this program, or we also have gotten some during our program. So thank you to everyone. Just going to take a look here just to see. We had a question during the webinar that came about, and it asked, what are medications? What other medications should people with Parkinson's patients not be given? And I think that we'll base this question possibly to Dylan or to Blanca, either of you. I think that's a great question for you to answer.
I could take a stab at that, and Dr. Valdovinos, please feel free to add anything. Yeah, I think the key classes of medications that we need to be wary of are anti-nausea medications. The fancy name for those are antiemetics, and also antipsychotic medications we also need to be mindful of too. So the anti-nausea medications, a lot of them can have those dopamine blocking effects. So the ones, I can list them out that we are trying to avoid in the hospital: Reglan, Phenergan, Compazine are the main ones. But the medications that are more safer, that don't have those dopamine blocking effects are Zofran, which acts more on the serotonin pathway, thank you. And the other medication that might be safe too would be Tygan, which we use at Highland, that doesn't have dopamine blocking effects either. And as far as antipsychotics are concerned, we really want to avoid the first generation antipsychotics. Haldol is the main one that's used in the first generation or typical antipsychotics. And then there's the atypical or second generation antipsychotics. And the majority of those we don't use, but we can safely use. Studies have shown that Seroquel, I think Dr. Braun mentioned, Seroquel has been shown to be safer to use in Parkinson's disease. And then there's also Clozaril, which I don't use in the hospital very frequently because it has the risks of causing issues with your white blood cells or your immune cells. So it's usually something that started more on the outpatient realm. But yeah, so Seroquel is something that is the safer medication to use for confusion or agitation at night.
Great, thank you. Another question that has come in during our presentation is, this individual knows that this is happening at hospital and affiliated regarding the drugs, but the question is, what happens when you go to another hospital system? So Blanca, can I route that to you?
Yeah, so I think, when we went to this team training conference in Charleston, there are, I think, 33 centers of excellence, Parkinson centers of excellence in the United States. So I think, and at this conference, there was probably 30 different groups that were there, teams from different hospitals. So yes, right now, you know, this project is for Highland Hospital and Strong, but there are other centers of excellence throughout the United States that are also trying to, you know, we're at this conference and we're trying to implement kind of similar projects and changes. So, you know, I know that it's not every hospital is implementing this. And I think, you know, it's something that, you know, we're trying to, you know, educate everybody about. But I think from our standpoint, I really think the big thing is like really the centers of excellence are the ones that are really kind of taking these initiatives. And I think the Parkinson's Foundation has a list of all the centers of excellence. And there's really centers in most states in the United States.
And I think the other thing I would add is that you can, yes, of course, not every hospital is going to have this going on, but I think that's where you can rely on those hospital-based resources, right, from the foundation that then, again, the burden falls obviously a little bit more on you, but to know those are available so that you can bring in, you know, an aware and care kit to any hospital, or you can use this letter to any hospital. So that's one of the ways that I think we're trying to, it's a really good point, but to try to address that.
Dr. Braun, I'm going to send this question to you. Should I bring my medications to the hospital with me?
I think that's a really good question and a difficult one to fully answer, because there are some medications that most pharmacies will have. For example, most pharmacies in the hospitals will have Sinemet, or the standard carbidopa-levodopa. However, it may not have every formulation. For example, we looked at the pharmacist, the formulary at Highland, and they don't have Rytari, which is a form of Sinemet. And then there's all the medications that are not related to carbidopa-levodopa, and some are on the list of what they have and some aren't. So my recommendation, and I'm happy to see what, for example, Dr. Richard thinks about this, would be it's always better to err on the side of bringing your medications, and that can also be helpful because it might give the specific times on the bottle, and that could be useful for the doctor putting the order in. So I think I would say better safe than sorry, but hopefully in the future they would have all of the medications at the hospital. But in the meantime, I think it's better to be safe.
All right, not reading lips today. So I would totally echo that. I mean, I think that we went through and, you know, a lot of the newer medications, particularly those that go through specialty pharmacies and require prior authorization, and most hospitals are not going to have those. But even some of the things that you might have expected that they would have, they may not. So if, for example, Dr. Braun had mentioned, you know, when I looked at Highland as well, they had all the different formulations of carbidopa-levodopa, as well as they had entacapone or Comtan, though they didn't have that combined pill, which the brand name of that used to be Stalevo. That actually brings up just one other point, that another thing that we did was we actually put in an instruction that anytime you order Comtan, it has to be given with the Sinemet, because that was something that people, the ordering doctors didn't realize that, but that's the way that Comtan works. It has to be given with the Sinemet. It's just one other thing. But yeah, I would bring your medications in and just make people aware that you have them. What they do with that will depend. I mean, usually if it's something they don't have, they will, it depends on the hospital, but often they'll take it and then they'll administer it to you, hopefully at the right time. So anyway, yes, I would agree. I would not hesitate to bring your own medications just to play it safe.
Great. Dylan, this question I'll send to you. When should neurology be consulted once you are in the hospital?
I think that's a great question. So a lot of times neurology doesn't necessarily have to be consulted. It's really only if we're thinking that medications need to be changed. And often what I would do rather is call the outpatient neurologist, the person that knows the patient the best, that's managing the Sinemet and Tacopone, Rytari, and any of these medications, and kind of converse with them and see what their thought processes are, and if they were planning on adjusting things if X were to happen. But another reason, to potentially include neurology, though, would be if they're very confused and you're kind of ruled out, an infection, or imaging is looking reassuring. Maybe you want to get neurology involved to get a better sense of things, and see if medications need to be changed. But I would say not in all cases does neurology need to be consulted, but certainly if there are concerns where we do need a neurologist, it would be definitely good to call them.
Right. And this is also, should the care team at the hospital touch base with the patient's outpatient neurologist?
Yeah, I've been trying to make it a habit of mine ever since going through this program, and really just trying to, be a team with not only the different providers in the hospital, but also the movement disorder neurologist, or neurologist in general, that's managing the Parkinson's disease. I think that I've gotten nothing but positive feedback from the neurologists that hear from me when I reach out to them and tell them, oh, your patient's here, and they appreciate learning and being engaged, and they might not have anything to change or add, but they appreciate that interplay or dialogue. Sometimes they do have some advice, maybe some changes that we could make that might be beneficial. So I think it's definitely something that I'm trying to make as a habit. And you could encourage your hospitalists or other providers to reach out to your outpatient neurologist.
Great, thank you.
I was just going to add, just real quick, that we usually encourage families also to, when somebody's hospitalized, for them to reach out to their neurologist and give them a heads up as well about what's going on.
Aubrey, we're going to send this one to you. So what are the requirements for going to a rehabilitation center? And the second part of that would be, would this be covered by my insurance?
Okay, so that's a good question. There are several factors that are actually required. The first one being that the patient or the individual in question has to have experienced a decline in function from their baseline. And this is assessed through a combination of assessments done by a physical therapist in the hospital. It takes into consideration the subjective history taken from the patient or the family about what their baseline level of function is, or the most recent baseline level of function. And then it also includes a in-depth objective assessment from the therapist at the hospital of the patient's present level of function. And then we compare the two. And then we also can use standardized or objective measures that can also further exemplify why a patient would require that level of skilled physical therapy intervention. Number two is that the recommendation has to come from a physical therapist in the hospital setting, plus or minus some of my rehab counterparts, such as occupational therapy or speech therapy. It's not enough to come into the hospital and have a family member or patient request to go to a rehabilitation center, or have a doctor say, I think you need to go to a rehabilitation center. There needs to be a standardized assessment and recommendation from a physical therapist. The second part of that question is the insurance coverage. It really depends greatly on your individual insurance carrier and your individual policy within your insurance coverage. Most insurances will cover up to 21 days of skilled nursing facility rehabilitation, with additional days allowed at a cost of a copay to the patient. Some insurances do have some requirements before the patient is able to be accepted into rehab and have it paid for. One is that the patient needs to have a medical necessity to require a 3-day inpatient stay at the hospital before they will pay for rehabilitation. And some insurances require a pre-authorization process in which the insurance company will review all pertinent documentation in your medical record or your chart so that they can assess and evaluate whether they feel that you are appropriate for that level of rehabilitation and that they will give you the A-OK to pay for it.
This question is for Amy. Will a hospital social worker help find the home care for if these individuals need to go to a rehabilitation center? Will the social worker help to the families and the patient to find the home care systems?
Well, we usually think of home care as you're getting care at home. So certainly if that's kind of more what they're asking about, these days as much of the RNs from usually the hospital system's kind of primary home care agency is often going to then be called in to start doing the evaluation in the process if indeed they're going home and they're going to need home care services. So if they need home care after rehab, so usually the social worker at the nursing home or the rehab center is going to be the one then that's going to be helping to drive the discharge plan and make the connection to home care from rehab.
I know that we did mention the ID bracelets. So one of the questions that came in is, do medical ID bracelets provide much to the ER admissions? So for that question, Dylan, would that be something that you could answer? Or the bracelets that they do provide if they have it on when they arrive at the emergency admissions? Is that helpful?
I haven't seen these bracelets, but certainly any way of notifying us about any concerns you might have would be helpful. So if it's in a bracelet and it's noticeable, I'm sure that we would see it. So anything that you want to provide to us, whether it's your wear and care kit or a bracelet or just back and forth communication, shared decision making, advocating for yourself in any way, we're all for that. So I think the bracelet's a great idea.
This is just a question that came in prior. How do you locate a good doctor in your area to treat patients with PD? So this will, hope Nancy, you'll be able to put this in the comment section, that you can go to the Parkinson's Foundation website to be able to find a center of excellence or doctors in your area that are accepting new patients, being a neurologist or a specialized neurologist in your area. So please use the website. That is a really good source.
And also the helpline is, if you're not, is probably, I think, in some ways as or even more helpful, because you can, these is a staff by folks that can help you wherever you're living in the country. And you can kind of give them your specific information, and I think they can be super helpful and easy to just call and find out about your closest ideally movement disorders neurologist in your area, in addition to the website.
Great. So I think that the other question, this will be for you, Aubrey, is that if when a person has received PT or goes to a rehabilitation program, would that be communicated to the individual whoever they're receiving their physical therapy in their community also? Will those notes and things be provided to them?
If it's within the U of R system, we have access to each other's notes. I read notes from outpatient therapists, therapists in skilled nursing facilities have access to my notes. If it's outside of our system, we can always communicate on behalf of the patient if it's requested, but we don't, as a rule, automatically send information to the next provider.
Well, I think that we've covered the majority of the questions that have come in. And at this time, we'd like to thank everyone from the Parkinson's Foundation for allowing us for this project. It's been great for all of us and in our community here in Rochester, New York. And I'd like to thank you all for joining us today. We are sending you with good wishes and to please stay well during these times, and happy holidays.
Many thanks to our wonderful colleagues at the Center of Excellence and at Highland Hospital. Thank you so much for all the hard work. And clearly this will pay off for many, many people with Parkinson's in our community. And just a reminder, if you're interested, here's the real deal here. The Wear and Care Kit, call our helpline so you can find out how to get it, or you can pretty much access any of our materials on our website. So feel free to visit parkinson.org. Thank you all so much for being with us today.
Thank you.
Thank you. Take care.
So.